So today I'm going to present my case. He's an 82-year-old active male who presented to us with an unstable angina. He is diabetic, hypertensive with history of ischemic stroke 2 years ago with chronic kidney disease of serum creatinine of about 1.7 milligram and GFR 39. His transthoracic echo showed global hypokinesia with left ventricular ejection fraction of 33%. We did a Salim study before proceeding to coronary angiography, which showed that all the cardiac segments were viable except for a small scar in the epicoceptal segment. So this is his coronary angiography. As you can appreciate here, we have a heavily calcific CTO in the LAD, proximal LAD. We have a CTO in the mid-circumflex, a bifurcating lesion down in the circumflex, and we have a lesion at the proximal obtuse marginal. We can appreciate it in this spider view. We can appreciate also that the segment lost in the LAD was a very long segment. The right coronary showed atherosclerotic disease, but with no significant lesions. We can appreciate that there was some retrograde, it was giving some retrograde flow to the left system. So we have two CTOs, one bifurcation lesion. Centric score was 50, Euro score 6.4%. The BCI CHIP score was 5. It was optimum for this patient to go for surgery, but the patient and the surgeon refused surgery. So we decided to do the left system on 2 sessions, the LAD first as a CTO complex case, then we go for the circumflex and obtuse margin at another session. So we shifted to 7 French sheath. The patient was aeupholemic, his blood pressure was okay, heart rate was stable. We didn't need to do hemodynamic we didn't need any hemodynamic support. So we had a standby ECMO, but we didn't insert it. So we can appreciate here, this is a bilateral bilateral injections. So we first inserted a fine cross microcluster, and we used a Gaia, Gaia second wire. However, the fine cross didn't proceed because of the heavy calcium. So I had to manipulate the Gaia all across the LAD, across the lesion. Successfully, I managed to pass the wire. Every time the wire passed into a branch, I felt a little bit assured that this is the true lumen. Sometimes it goes in a diagonal, another time in a septal. We're always confirmed by a contralateral injection from the right side. We can appreciate we are here in the true lumen to reaching the very distal end of the LAD. Now we tried to pass a 1O balloon, and you can appreciate it didn't pass. So we decided to do a granuloplasty. We intendedly ruptured the balloon. Then we used another 1O balloon which passed, multiple pre-dilatations. Then we exchanged with another workhorse wire. We can appreciate we restored flow in the LAD. There is some dissection. So we stented the LAD from distal to proximal, 2.5 by 38 drug-eluting stent, and another 3 by 38, another 3.5 by 38. We did post dilatation with non-compliant balloons, and this was the final result for the LAD. We stopped for the LAD. We then went for the CTO, CX, and obtuse margin 3 weeks later. I thought it would be a piece of cake because the last segment was short. I began with a pilot 50. It passed. Began to pre-dilate. However, this was the extent of the balloon. A 2 by 15 balloon didn't pass past this lesion. So I tried to do a leopard technique to do like a tunneling to for the balloon to pass. Didn't work well. We lost the flow. Then I thought that I might use an anchor balloon technique. So I decided to wire the obtuse margin. I brought a P2 wire. However, the P2 wire didn't pass easily in the obtuse margin. It kept on going in this branch. However, while doing some manipulations, I think that they dissected the obtuse marginal and there was some flow lost. So I kept the wire in place. I used another wire, a run-through wire, which passed easily. After some manipulation in the obtuse marginal, I pre-dilated this lesion in the obtuse marginal. Then I brought a 1O balloon. It passed easily in the circumflex. However, again, the 2O balloon didn't pass. I did a granuloplasty. Maybe it works again. Didn't work. So I decided to use another wire, a pilot 150. And as you can appreciate that the pilot 150 took another turn. Maybe the pilot 50 was in a dissection. Maybe the 150 did a dissection re-entry. I didn't have an IVUS to appreciate to study why the wire took this bend. However, when the semi-compliant balloon passed easily. Now, as you can appreciate, the semi-compliant balloon passed distal to the lesion. We pre-dilated well. Now we have restored the flow. So we began to stent. I brought a stent 2.5 38 didn't pass. I brought another larger balloon. Now it passed. So we did an inverted decay crush, with considering the obtuse margin, the larger branch, as the mother vessel. Then after crushing the stent, we crossed the wire, first kissing balloon. Then we insert 3.5 by 48 drug eluting stent, pot. The balloon didn't pass, anchor balloon for the second stent, for the second kissing balloon, a repot, and this was our final result. So my take-home message is recent advances in the PCI technology have provided an excellent solution and an alternative to CABG in patients with high surgical risk. Always study the patient angiography well and take your time in planning the revascularization study. Do not attempt any CTO except after being fully prepared and knowing what you have in your toolbox, and do not get it stuck in the failure mood, and always have a plan B and C to troubleshoot obstacles. Thank you.
Thank you.